We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, welcome to the new A Pinch of Salt, a podcast series offered by the ERA. I'm George Kosmadakis, your today's host, and we'll discuss about onconephrology, a huge subject. Have you experienced, as I have sometimes, moments of solitude when the oncologists are calling you to ask about the degradation of renal function in patients treated with unpronounceable agents carrying exotic names, usually finishing in MAB? Well, join the club. The agents used in oncology are evolving with such a speed that sometimes we find it hard to keep up with the pace. In order to clarify a little bit these issues, today's guest is Kenar Jhaveri, Professor of Medicine and Associate Chief in the Division of Kidney Diseases and Hypertension at Northwell Health and Zucker School of Medicine at Hofstra, Northwell, USA. He is an eminent world-known specialist in onconephrology. Kenar, welcome to the Pinch of Salt.
Thank you for having me. This is great to have onconephrology in the forefront in your podcast.
Well, thank you. Thank you for accepting the invitation. It's really very exciting. So, Ken, I would start straight away with the first question. Is onconephrology a new subspecialty? Which is its scope?
I don't think it's new. I have been practicing onconephrology since 2009, and a lot of people have. If you work in a cancer hospital, you've been doing onconephrology for years and decades. There are a few cancer hospitals in the world that are just dedicated to cancer patients. So they've actually been doing that for many, many years. Actually, one of the first books written in onconephrology was back in 2005 or 2007. So way back in the days. One of the first onconephrology symposiums done by ASN was in 2009 or 2010. And the first pre-course, I believe, was in 2013. But in terms of taking care of patients, especially with cisplatin nephrotoxicity, methotrexate nephrotoxicity, nephrectomy patients with CKD, myeloma, amyloidosis, we know we've been doing that for years and years. What has changed in the last decade is perhaps the advancement in oncology medications. So as new medications became available in oncology over the last decade or a little bit more than that, the toxicities have gotten much more complex and the knowledge base has increased as the oncology medications have increased. So that's where the advancement has led to more interest in onconephrology.
So this change of paradigm in onconephrology treatments has led to a change of paradigm in the onconephrology evolution and the way we see things. Eventually, the reactions of the kidneys in the new agents are much more complicated and elaborate than before. So we are found sometimes a little bit lost. And I wanted to ask you, is there a reference or a site where we can adequately be informed on renal effects of various oncological therapeutic agents?
So before we get to that, I wanted to just let people know that the renal toxicities, a lot of these medications are still very, very rare. For example, immunotherapy is a big one. Like, people use immune checkpoint inhibitors a lot for cancers these days. The incidence of immunotherapy-induced AKI is still like 1 to 2%, maybe 3%, compared to other toxicities like skin and diarrhea is much more common. So while we might be seeing these toxicities as nephrologists maybe more commonly, it's still not very common for the oncologist to call us because it's not in their radar as much more frequent as other toxicities. So just, we want to put the big picture in perspective. You don't want to just narrow it down to nephrotoxicities. In terms of references, I think, we have a few up-to-date chapters that summarize these toxicities, and we update them very frequently. It's the renal toxicity chapter on both standard chemotherapy and molecular targeted therapy. So, if people want to go there, it has very updated data, and we update that very frequently as new medications come along. There are several review articles that you can reference. Recently, in terms of what you're looking for, there is a very nice paper by Mitch Rosner and Mark Parazella. That if you want, I can send you the reference that you can put on the chat with the podcast. But the journal called ACKD, if you remember, it's now called Advances in Kidney Disease and Health. In 2023, had 2 issues dedicated to onconephrology and has at least maybe close to 20 reviews on different topics in onconephrology. And that's probably the most recent updated, series. And more recently, Kidney 360 has been doing an update in onconephrology almost on a monthly or every 2-month basis on different reviews of different topics in onconephrology. And that's the most recent things for you guys to kind of follow.
That was a very nice citing of the most recent ones. I can cite as well a relatively recent article on in NDT, the European Journal of Nephrology, concerning the immune checkpoint inhibitors and the nephrotoxicity. It's a very interesting article. So there are references, which means that there is an interest in this part. And which are the top 5 agents associated with renal complications? How these complications are presented? You said that for most of the newer agents it's rare, but it's exotic at the same time, because exactly it is a rare thing. But we have other agents that have a real renal toxicity profile. Could you cite some of these agents?
Yeah, so I think let's start with the standard chemotherapy. I think the 2 most common that everybody knows and should know is cisplatin and methotrexate. And cisplatin, the most common injury is tubular toxicity and maybe hypomagnesemia. The methotrexate causes more crystalline nephropathy, again, more form of a tubular toxicity. And those 2 are, we know so much about those 2 medications, yet we have no preventive strategies or anything that's available. But I think there's more data to come soon on perhaps magnesium being preventive in cisplatin toxicity. And methotrexate, we do have some recent data on, glucoparidase perhaps as a potential treatment. Now, the other 3 drugs I would think about, one is immune checkpoint inhibitors.
Yeah.
I think that's such a very hot topic right now in oncology. And the most common kidney biopsy finding is acute allergic interstitial nephritis. I mean, is it allergic? Was it an immune reaction? We don't know for sure, but it is 83%, 84% biopsy-proven cases is all AIN. And we do see some GNs, ATN, but that's much, much rarer. Okay. Now, the other 2 I would pick, one is bevacizumab. Bevacizumab is used for several different cancers, and it's an anti-VEGF agent. In some countries, it goes by the name of Avastin. And it's, what's exotic about it is causes thrombotic microangiopathy that's renal limited. And I think that is something that, we as nephrologists, we're not very used to seeing a lot of these cases, but I think a lot of that class of drugs, tyrosine kinase inhibitors, the VEGF inhibitors, a slew of them, I would say at least 20 drugs that fall in those categories, all cause renal limited thrombotic microangiopathy. It's very hard to treat, very, very challenging, in especially countries with low resources where we cannot get anti-complement therapy. It's very, very challenging. The last one I would pick is probably a drug that maybe people won't think about, but we do see drug-induced tumor lysis syndromes, and one of the big ones is venetoclax that's used for CLL. And it causes, and that few of those class of drugs cause drug-induced hemolysis syndromes, and that we don't see as frequently as we used to think about as these drug agents are coming out to treat, those leukemia lymphomas. And those are the five I would just, off the random pick as something people should know about, or different rare disorders seen with them.
Well, it's fascinating. You see, you can see a wide range of toxicity, of renal toxicity, and you cited almost all subtypes of acute kidney injury here, provoked by these agents, and effectively we see more and more these problems with immune checkpoint inhibitors. I think also due to the fact that there are more and more patients treated with this group of agents, and well, how can a nephrology could adapt himself in this era of continuous introduction of new antitumoral agents?
I think if you're a general nephrologist practicing both in an academic or community setting, I don't think you need to know about every drug, but at least you should be aware of where the resources are to go look for the toxicities, or at least have a phone a friend. So if you have a group of nephrologists practicing and one of them is interested in onconephrology, you call that person, hey, have you heard of this drug causing this degree toxicity? And you get that help from them while you're taking care of that patient. Or you go to the resource and read about it when you try to treat these patients. I think being aware of everything is going to be impossible. Even I don't, as an onconephrologist, don't know everything about those drugs. I always have to look it up. And it's important to know what your limitations are and go ask for help when needed.
Well, this is a very interesting answer, an answer actually by a specialist in onconephrology, and I was always considering that the amount of knowledge is really increasing, and sooner or later we'll all be obliged to be more specialized in specific things concerning nephrology. And nobody was shocked when we had the transplant nephrologists and the dialysis nephrologist. But you see, now we have more and more information concerning kidney stones, concerning the physiology, concerning the onconephrology, and we should have people to refer to if we don't want to check at the sources in bibliography. So this is a very interesting piece of advice concerning the organization of renal care in various settings. Thank you very much, Kenar. And now I will ask you the bonus question, the most personal one, which is if you were in a desert island, which book, luxury item, and two songs would you take with you?
So I'm going to twist it around a little bit. I actually will take two books. Um, One of them is my favorite, is the Book of Joy by, I don't know if people have read it. It's, about Dalai Lama and Desmond Tutu, and it really teaches you about life. And the other book is actually Ikigai, the Book of Ikigai, the way the Japanese live their life of simplicity and the passion in life. What brings passion? What do you wake up in the morning to look forward to? And for me, it's nephrology is one of them. So it's, what brings ikigai in your life, the passion. And I think that's two things that are very important wherever you go, if you're especially in a desert island. In terms of songs, I'm a big Bollywood, fan. So I would probably take a whole collection of them, not just one, because there's so many that are near and dear to my heart. In terms of a luxury item, it probably would be,
Kenar,
yeah.
we'll do a playlist at the end of the year. So if you have two specific songs, that will be nice, because we'll not put the sources, but we'll have a playlist at the end
You
of the
will.
year.
That'd be
Yeah.
great.
So if
Okay.
you have two titles to give it, it will be wonderful.
Okay, so one of them is Angrezi Mein Kehte Hain. That is a very old song. And the other one is Jab Koi Baat Bigad Jaye. Is another favorite song of mine. In terms of luxury item, I would take a picture of my family.
You're not the only person. You know, a lot of people, and somebody said that he would make it undistractable. You know, he would put something to protect it. Wonderful. So, dear colleagues, there is still hope to find ourselves in this evolving therapeutic landscape. And a new working group in onconephrology has just been created by the ERA, and we'll have plenty of insights from them in the coming months and years. This is confirming what Kenar has just told us about the evolving um, landscape concerning onconephrology. Thank you for joining us today, and other podcasts are available in all the main digital platforms. Thank you.
Thank you.